is helpful now for this. You see, like this mean deviation. So if you have, if this patient today is 2.2, if next time they come at 4.5, that is more than 2, okay? So that's a patient, you should either repeat the test and make sure they're not progressing. So that's the cutoff. Rapid progression, 2.2. For the nerve fiber layer defects, you'd like to keep it at less than 4 microns. These were photos we took from, we had this chart to help us monitor follow-up with our tests. So 4 microns of the RNFL. So one thing with glaucoma, it's it's a long-term relationship you have with your patient. My supervisor used to say, forever till the end of day. Either I pass away or you pass away. Okay? So there's this relationship you have with your patient. You don't have to hold them like this, but you have a relationship with your patient. So that communication also comes into play with your management of the disease. So from this, I hope you have a take-home message of your own. I know I gave you mine, but I hope you'll be able to have a take-home message and hopefully diagnose better and follow up more objectively and keep your patient on target. If they're progressing, you want to revise your target. Most of the time, people will do it at 30% reduction. Then there are always those patients who you really try, and unfortunately, sometimes with glaucoma, it's a slippery slope. You're not able to do much. But if you keep these concepts, most of the patients will slow down their progression. So these are the references, and thank you so much for your time and for also being engaged.
Thank you, Dr. Lily, for the very enlightening presentation. I think we can do better with the applause. Let's give her a good round of applause. Thank you. So very quickly, I'll introduce the next presenter. That's Dr. Hatim. So one fun fact about Dr. Hatim and I is he's the one who taught me how to comfortably use the indirect ophthalmoscope during my residency. So for that, I'll always remember him. So Dr. Hatim is a graduate of the University of Nairobi. He did his Bachelor of Medicine and Surgery and then his M.Med in ophthalmology at the University of Nairobi. He further went to specialize in vitreoretinal surgery in India, and he's a consultant vitreoretinal surgeon working at Kenyatta National Hospital. So Dr. Hatim, you have 10 minutes to tell us about uveitis. We'll take the questions and answers after the two presenters. So if you have any queries for Dr. Lily, Dr. Hatim, just note them down. We'll have a Q&A session after he presents. You're welcome.
Good evening, everybody. I know Dr. Lee Nyamari focused on the disc. Now I'm going to look at the whole eye. Dr. Hatem is here, Dr. Oscar is around, Dr. Kareko. For us, disc is okay or not okay. And it stops there. The rest, we leave it to the glaucoma guys to have a look at it, and the neuro-ophthal guys. I'm going to be talking about uveitis. It's a big and vast subject. I know it's an enigma to most of you, but something to take home is it is a very interesting subject. I'm very passionate about it, and I do see a lot of uvea cases over the years. So it's actually the inflammation of the uveal tract, third leading cause of blindness in developing countries. Prevalence varies, as I've mentioned, and anterior uveitis is most common. Now, this is the pathophysiology. It's actually an inflammatory cascade. So you can see where the steroids act and the other anti-inflammatory, how they work. So classification, We classify uveitis based on the location. So it can be anterior, intermediate, posterior, or a pan-uveitis. Today I'm going to be covering anterior, intermediate, and posterior. And in terms of the duration, it can be acute or chronic, and types granulomatous or non-granulomatous. This actually helps you to process what would be the etiology in the patient. Now, symptoms, they usually present with redness, pain, photophobia, epiphora, blur, scotoma, and floaters. Now we come to the signs. So, this is something, I know Professor Kishui is not here, but he always used to emphasize one thing when we're doing postgraduate. Your examination of the patient begins from the time when he walks into your clinic, not when he sits on the slit lamp. And this is what I also keep on telling the residents. Look at your patient from the time they walk into your door until the time they sit down. How they move, everything will give you a clue. So when you look at the eyelid, you're looking at vitiligo, nodules, lesions. The conjunctiva and sclera, you'll also be looking at injection, nodules, thinning. In the cornea, keratinic precipitates, fibrin, pigment, corneal edema, band keratopathy, and ulcer. So you can see in this image, in the bottom, you can see the KPs in the corneal endothelium. Now, all these have a bearing as to how you're going to move forward in terms of diagnosing the patient. Now, signs, anterior chamber, you'll be looking for cells. This is how we grade the cells, and flare. Flare actually tells you that there has been an inflammation before, not necessarily that there's an active inflammation at the time when you're seeing the patient. I've been given 10 minutes, so I'm going to rush. Brenda, you're very stingy on time. So, when you're looking at the iris, you'll be looking for nodules. So these are inflammatory nodules. Busaka nodules happen at the border of the iris. Koepe nodules. You'll be looking for posterior synechiae, anterior synechiae, heterochromia. This normally happens in Fuchs. Granulomas, atrophy of the iris. This is a very important sign, especially in patients who present with viral uveitis, which is actually prolonged. You'll get iris atrophic areas. Cyclitic membrane formation and iris bombae. Now, just to mention on the atrophy, I have a patient whom I've been seeing for over now 6 years. She usually comes with anterior uveitis every now and then. I actually saw her when I was working in Lions, and just based on the atrophy of the iris, I started on antiviral therapy. And since then, she's been stable. She gets flare-ups whenever she stops the antiviral therapy, mainly acyclovir, okay? So angle signs, I think Lily has talked a lot about the angle. So thank you for that. So we'll be looking at nodules. These are inflammatory nodules in the angle. Vascularizations, peripheral anterior synechiae, as you can see in the image there, and secondary ciliary body detachment. IOP, you get hypotony, increase in IOP because of posterior synechiae formation. I think we've had a lot of these on the glaucoma talk. Now we come to the vitreous. You'll be looking for cells, flare, snowball opacities, snow banking, and vitreal strands. Now, something I want to make it a bit clear to everybody. When it comes to snowball opacities, snow banking, preferred mode of examination, use your indirect. I think the VR surgeons are going to agree with me. You're using your slit lamp, you're not going to reach there. And most of the times, these patients do present with pars plana membranes, so you'll have to actually depress the eye to look very carefully at the aura. So in the retina, you get retinochoroidal inflammatory infiltrates, sheathing of artery and veins, retinal detachment in case of exudative retinal detachment, RP, hypertrophy or atrophy, atrophy or swelling of the retina, choroid and optic nerve head, and macular edema. So you can see this image where you can see the vasculitis in the patient, and you can see the fluorescein angiography image with inflammation around the vessels with staining. Now, what are the complications? You get cataracts, glaucoma, band keratopathy, and cystoid macular edema. Now, we come to each entity. So, acute anterior uveitis, HLA-B27 diseases, glaucomatocyclitic crisis. Sorry, I'm an Indian, I shrub it sometimes. Lens-associated uveitis, you can get post-operative inflammation, which is IOL-associated, and infections. So HLA-B27 diseases. I know anterior uveitis is something which we all do see in our clinical practice on and off. So seronegative spondyloarthropathies are strongly associated with acute anterior uveitis and HLA-B27. So these are the diseases that are included in that group. Okay? And one thing to notice about HLA-B27 uveitis, normally these patients, ideally when they present to you, it's like the way how somebody gets a migraine. They can actually tell you that they get a prodromal phase in which they can actually tell you this inflammation is, I know the inflammation is coming, okay? And most of the times they will not present with bilateral disease at the same time. They usually have one eye which gets affected and then the second follows suit. And most of the times these patients come with inflammation and low IOPs. So you can see ankylosing spondylitis, you get a bamboo spine, okay, on the X-ray, and they usually have acute anterior uveitis. And most of the times they usually present with fibrin and hypopion with HLA-B27 associated diseases. And as I mentioned, they usually get one eye and then it affects the other eye. Reactive arthritis syndrome, so they have a triad of non-specific arthritis, polyarthritis, and conjunctivitis. Then we have psoriatic arthritis. These are all part and parcel of the HLA-B27 disease group. So these usually presents with inflammatory arthritis, okay, and usually get changes in the phalanges. And you'll be surprised. Most of the times these patients, when they sit on the clinic, by the time they sit on the slit lamp, by the time you look at their hands, you'll be able to make at least a conclusive diagnosis of what you are dealing with. And 20% may have sacroiliitis, and they usually develop iritis. Now, glaucomatocyclitic crisis. They usually get recurrent unilateral mild acute iritis. They present with high IOP, corneal edema, low-grade cell and flare, and slightly dilated pupil. Duration hours to days, and usually associated with HLA-B54 disease. Now, the other condition that usually presents like this in a very similar manner is viral uveitis, Postner-Schlossman syndrome. These patients usually have a viral uveitis which causes the pressure to go very high up. And they do come. Sometimes they'll come with pressures of 48, 50. You put them on antiviral therapy and anti-glaucoma medications, and they usually do resolve. I remember a case we had when I was doing my residency, my postgraduate training. We had a case with Professor Gishui, who usually used to come on, keeping on coming with uveitis on and off, on and off, on and off, until we finally decided enough is enough. We couldn't make heads or tails out of it. And you know, in our setup, we don't have most of the investigative modalities. But in an ideal setup, you do an AC tap and send for PCR. So we decided to give this patient subtenon steroids. Lo and behold, we gave steroids. The patient came back after around a month, and we could actually see what we had missed early. The patient actually had deciform keratitis. We could see the KPs around a circle with corneal edema only left in that area, and we could treat the patient. Lens-associated uveitis, immune reaction to the lens material, granulomatous or non-granulomatous. KPs can be small or large, okay? They sometimes present with hypopion, posterior synechiae, elevated IOP, and vitritis. Now, some of these things also fall under Lily's realm, lens-induced glaucomas, but something I want to mention here, okay? You get a patient who has had cataract surgery, it's uneventful, the patient has been okay, and they come with a bout of inflammation. You give steroids, they get better. Then they come back again with a rebound bout of inflammation. You give steroids, they are okay for the period when the steroids are okay on treatment. Once the steroids resolve, they come back with the inflammation again. Any takes? What would you be thinking about? In such kind of patients, I would actually do sorry? Yes. No after cataract. You just see some bit of haze in the capsule, but they keep on coming back with recurrent inflammation, Propionibacterium acnes infection. Something to think about. And the treatment of choice is actually vancomycin. You give vancomycin into the bag. In the anterior chamber, you give injection of vancomycin into the bag. It actually helps to clear it away. Worst comes to worst, remove the whole IOL in the bag. Something to think about. Now, this is an ultrasound. I've put it here because I'm going to tell you something which I faced during my fellowship. You can see the ultrasound on your right-hand side. The lens echo is in place. You can see the optic nerve head and everything is clear. On the on your left-hand side, you can see there's a globular echo and there's vitreous inflammation. We actually had a patient who came with, had some trauma, came to us, query surgery, query no surgery. It's all an enigma at times. Came with inflammation in the eye. Actually had hypopion, severe inflammation. When you look through, you see there's a membrane, pupillitic membrane. You couldn't tell what is happening behind. We were sent to do an ultrasound. We did an ultrasound, we came back. We were very happy. Vitreous echoes, endophthalmitis. And the worst thing is, I never used to speak very good Tamil. So it was a very difficult thing communicating with a guy who has come from the village. So we actually had to call in someone to sit down and take a history. And eventually the consultant told us, go and check again. Do an ultrasound properly. I am sure the lens has fallen behind. And lo and behold, we actually did an ultrasound and found that the lens had fallen behind with a ruptured capsule. And that was giving the patient all the inflammation in the eye. Drug-induced uveitis, sometimes we are the cause. So you can see most of these drugs, they do cause uveitis, prostaglandins, myotic drugs, pilocarpine, intracameral drugs which we normally use, antivirals, antibiotics, all these. And I don't know how many, okay, I'll ask the VR surgeons. We've been getting a lot of this problem since the advent of COVID vaccine. I don't know how many of you have seen. Patients who receive COVID vaccine come with severe inflammation in the eye, with vasculitis. I think me and Dr. Jaffarji, we have seen, I think, around 3 to 4 patients with this funny kind of presentation. So infections, herpes simplex. Normally we know they usually present with herpes zoster ophthalmicus. They'll have a staining ulcer, dendritic ulcer. They sometimes also present with deciform keratitis, something to look out for, okay? And CMV and Epstein-Barr virus also causes anterior uveitis. And the best way to diagnose Epstein-Barr virus is to do a AC tap and do PCR, which we don't have in our setup. So chronic anterior uveitis, those are the acute forms. Juvenile idiopathic arthritis, Fuchs heterochromic iridocyclitis, and idiopathic, where the doctor is idiot and the patient is pathetic. That's why it's called idiopathic. This is what one of our lecturers used to say. So juvenile idiopathic arthritis, most common systemic disorder, okay, in children. Iritis usually develops within 5 to 7 years of onset of joint disease. Female anti-nuclear antibodies, negative rheumatic factor, and usually these patients, they usually present to you with a white and uninflamed eye. They don't have redness, nothing. And you'll find there's an anterior chamber inflammation, usually have posterior synechiae. Some have even to the extent of complications of uveitis. Now, just to mention on this juvenile idiopathic arthritis, I've had a patient I've been seeing since the year 2018. Young girl, now she's around 16 years old. She actually came with bilateral uveitis, severe uveitis. She was seen when I was in Lyons, had multiple peripheral iridotomies because of severe inflammation, angle closure, inflammation which was not settling down. Then eventually she developed a cataract. I did a cataract surgery with no lens and vitrectomy in one eye, and the other eye we did the same thing, lensectomy and vitrectomy. She actually used to come with the knee joint swollen, huge. We always used to think it's arthritis until I sent her to the pediatric rheumatologist and did a biopsy. And lo and behold, what they found was amyloidosis. So she used to come with this recurrent inflammatory bouts in the eye. Right now, she has got good vision. She's in school, but not very good vision, but she's maintaining. Fuchs heterochromic cyclitis. They present with unilateral uveitis, heterochromia, okay? And they get these small white stellate KPs. Synechia almost never forms in this condition, okay? And associations are toxo, HSV, and CMV. And you know, in these patients, when you do surgery, when you make a paracentesis, you get bleeding in the opposite side. Amsler sign, something to look out for. Anterior uveitis, there's still a lot we can talk about, but I'll end there, and we go to the intermediate uveitis. Primary site of inflammation is the vitreous. This is how it's been called before, and normally patients present with blurring of vision and floaters. CMO, major cause of vision loss, and peripheral retinal phlebitis is very common. So in this diagram here, you can see actually the vitreous snowballs here, and here you see the peripheral phlebitis, this inflammation around the blood vessels. Disease associations often idiopathic, multiple sclerosis, not very common in our setup, sarcoidosis, Lyme disease, toxocariasis, inflammatory bowel disease, syphilis, TB, cat scratch disease, not very common as well. Something to remember, you see intermediate uveitis in an elderly patient. Always be worried about masquerade syndrome and Whipple's disease. Now, investigations. No specific laboratory tests. You go by the history of the patient. Whatever you think is significant, investigate according to those lines, okay? And tests are performed to rule out common or treatable causes. I know most of the times patients go to people and you find, it's called machine gun therapy. Physicians like doing that a lot. You have chest pain, they tick 10. You have breathlessness, they tick another 10. You have pain in the loin, they tick another 10 investigations and they send you. When you come back with the results, the doctor is confused, you're even more confused. So always target your therapy towards what you think is the patient is suffering from the history, okay? Minimum workup which is required is you do serum S levels, you're trying to rule out sarcoidosis. Chest X-ray nowadays, I personally don't prefer doing chest X-rays because most of the times they turn out to be normal. If you want to work up a patient with intermediate uveitis, order a helical CT of the chest. That will give you more diagnosis and more clues towards what is happening in the patient. Chest full blood count, syphilis test, and TB gold for interferon. Ultrasound, FFA, and OCT are one of the armamentariums you have in terms of diagnosing any sequelae of the disease process, not as a primary mode of trying to find out what is the cause. Complications, cystoid macular edema, cataract, glaucoma, retinal detachment, all these are part and parcel of the complications. Now, treatment. it's directed towards the specific cause if it is found. Okay? Patients with visual acuity better than 612, don't treat them, observe them, unless they have severe floaters and blurring of vision. Okay? And they have CMO, cystoid macular edema, retinal neovascularization, retinal vasculitis. Okay? And the options you actually have is corticosteroids in your armamentarium of treatment, immune suppressants. I know we all tend to shy away from them, okay? But this is something which is actually one of the arms we have in the treatment of patients who have persistent intermediate uveitis, cryotherapy and laser for the vasculitis, and vitrectomy. Vitrectomy, actually what it does, the vitreous acts as a sponge and keeps the inflammatory antigens within the vitreous. So what you do is when you do the vitrectomy, you're actually reducing the inflammatory load in the eye. Now we come to posterior uveitis, infective, toxoplasmosis, herpes, TB, syphilis, and fungus. Now, in this image, you can actually see, this is a headlight in the fog image, classical of toxoplasmosis. And one thing to remember, toxoplasmosis lesions, normally you'll find if a patient has had toxoplasmosis before, they will have a scar, and next to the scar is where the next lesion is going to start. You will never have a scar in one place and then the toxoplasmosis gets reactivated in a different area. Very, very unlikely. If that is the case, then rethink your diagnosis. Like in this case, you can see there's a scar here. This is where the toxo was previously. It healed, and you're getting a retinitis around here. Okay? Now, viral retinal necrosis. This is acute retinal necrosis due to herpes simplex. You can actually see the necrosis happening here in this area. Okay? Most important thing in these patients, avoid steroids and start them on antiviral therapy. The sooner the better. The longer you take, the more the virus is going to eat up the retina. And this is how the retina looks after actually it has healed. And these patients do require very close follow-up, okay? The reason being that wherever the viral retinitis has healed, there's a very high chance of getting atrophic holes and getting a retinal detachment later on. And that is a debate, if we start today, I don't think we'll finish tomorrow, whether the two schools of thought. People believe that when you have viral retinitis which is actually healed, some people believe in doing barrage laser. Some people don't. I'm the school of no barrage laser. I observe the patient. Unless if the patient is somebody whom I know is notorious, is not going to come for a close follow-up, then you can think about it. That was ARN, acute retinal necrosis, and this is PON, progressive outer retinal necrosis. So you can see here in this image, these necrosis in all these areas. Now, we have a case we saw 3 weeks ago in Kenyatta. One eye, post-trauma thicical. He has only the left eye, a gentleman, middle-aged, around 30-something, if I can recall the age correctly, came with reduction of vision in the left eye. He had actually been referred to us with a diagnosis of a retinal detachment. But when we looked inside the eye, we could see that there was a lot of vitreous activity, and in the superotemporal arcade, superotemporal periphery, we could see a whitish lesion, almost similar. This is how it's actually healed, but in active retinitis, it's actually white. Now we were at a dilemma. Are we dealing with TB? Are we dealing with viral retinitis? So actually put him on acyclovir tablets and asked him to do workups and TB gold quantiferon. He came back after 2 weeks. The floaters were still there, vision was still the same, unhappy patient, but the viral retinitis has actually started healing. However, his TB gold quantiferon was positive. And I know normally patients don't follow textbooks. You can always have 2 diseases at the same time. So I've actually referred him to the TB clinic to start anti-TB therapy whilst he's still on the antiviral therapy, acyclovir tablets. I'm planning to see him within the next 2 weeks. Now, I'll give you, in the next slide, I'm going to give you another story. This is TB. TB usually presents, you can see in this, you see the choroiditis. This is amphigenous choroiditis. Here you see the TB lesions following the blood vessel. This is serpiginous choroiditis. And this is miliary TB, your classical. 3 forms of presentation. Now, this is a patient who had been referred to me. He comes from northeastern province. A young gentleman came with reduction of vision. He actually had a detachment in this eye. There's exudative detachment. And these are photos which are taken from my phone. So you can see here, this is a subretinal abscess. Over here also you can see, there's a subretinal abscess nasal to the disc and at the macula. And you can actually see, when you do fundoscopy, that he has a whole massive exudative retinal detachment which shifts with the fluid as he moves. This is a patient whom, even without doubt, I started him on anti-TB therapy. He disappeared, so I hope he's doing well. And this is another presentation of TB. Usually get neuroretinitis. You can see here, this is a macular star with disc edema, and the same here. We had a patient 2 weeks ago in Kenyatta, had been referred with a diagnosis of an epiretinal membrane in one eye, the right eye. This patient actually, he's around 16 years old. When we examined him in the clinic, the left eye, the vision is very poor. If you look at the retina, he has actually foveal thinning in the center area. But when you examine the right eye, which was his better eye, now he started reducing the vision, we could actually see that he had retinitis at the macula and disc edema. But the thing is, he was a very clever patient. He was not divulging his history. And you know the problem with is when a resident asks questions, everything is a no. When the patient goes to the consultant, things change. I don't know if it has happened to any one of you. When the consultant asks, have you ever been treated for TB? Yes. And lo and behold, the guy had actually been treated for TB 2 years previously. 2 years or 1 year, if I don't recall exactly how much time it had been treated for. And he had only been treated for 6 months. So we restarted him on anti-TB therapy, and he came back after 2 weeks. And actually the vision had improved, the retinitis had improved. And me being the hero, I started him on steroids because of Jerry's Hexheimer reaction. I am hoping to see him after a month. This is the other presentation of TB, Eales disease. It's not a form of uveitis, but it's a form of vasculitis, peripheral vasculitis. Patients usually present with C-fan neovascularization, and some of them do present with hemorrhages as well. So when you see this funny peripheral vascularization in a patient, a young patient, think about TB. You'll be surprised. And most of these patients require peripheral laser to be done. Now, before I go to non-infectious causes, I'll give you another story. I have a patient whom I'm mentioning with another colleague of mine. She is a learned patient. She has had intermediate uveitis for quite a long time. Now, one eye is stable. She has got around 6/9 vision. The left eye, she has had an armamentarium of surgery. She has had cataract surgery done. She's even had an Ahmed glaucoma valve put in. She came to me with cystoid macular edema at that time. I saw her, and when I looked at the eye, I was like, I thought of TB. So I actually sent the patient for TB tests. Now, you know, us doctors also, we change our mind as we go along. Huh? The patient came back after 3 weeks. TB test was positive. Then, you know, I started having doubts in my head. This is a patient who is on rituximab, golimumab, methotrexate, courtesy of the rheumatologist. So I was like, this patient has taken so many immune suppressants, and here I am investigating this patient for TB. So a doubt came in my mind. I said, no, I don't think it might be TB. Maybe it's a false positive test. So I told her, if you're taking all these immune suppressants over this past like 6 months, 8 months, and you've not presented with clinical TB, I highly doubt it is TB. Still, I wrote a letter to the rheumatologist and asked, like, this patient has presented with TB gold quantiferon, which is positive, and having intermediate uveitis for which I could not exclude any cause, I have a doubt. And lo and behold, by the time she went to the rheumatologist, after around a month, she actually went with a huge lymphadenopathy, lymphadenitis. We did a biopsy and actually proved to be TB. And she's now on anti-TB therapy. So sometimes always the first thing you think about, stick to it. I actually changed my mind when the results came. I became a doubting Thomas of my own. As I said, you've been on anti-immune modulators for such a long time, I highly doubt it could be TB. Non-infectious causes, sarcoidosis. Now, I'm going to Vogt-Koyanagi-Harada syndrome. I know we all say it is rare. You know, like eating rare steak. But this is very common in our setup. We all tend to miss it because we never think about it. We always think it's a Caucasian disease. No. We've seen quite a few cases of this in our setup. Behçet's disease, yeah, in our setup, not very common. I only have one patient whom we are following up with one of the Aga Khan teams for a very long time, over I think 7 years. She has got Behçet's disease, sympathetic ophthalmia, sarcoidosis, chronic granulomatous inflammation that can affect any organ system. Remember that. Most commonly involves lung, thoracic lymph nodes, skin, and eyes. Anterior segment, you'll get mutton fat capes, nodules, and in the posterior segment, as you can see. However, we've also had a case of neurosarcoid. A young patient who actually came with massive disc edema and loss of vision in one eye. We did an MRI and we found that there were nodules, okay? We could not find, it was not TB, but eventually ended up being neurosarcoid, which was affecting the optic nerve, excuse me. Behçet's disease, in our setup, not very common, okay? They usually presents with all these triad. They usually have oral ulcers, pseudofolliculitis, genital ulcers, arthritis. They have skin problems. They have anterior chamber hypopyon, epididymitis, thrombophlebitis. And these are usually associated with HLA-B51. And it is usually very common in the Caucasian population. Africans have hardly seen with this disease. Now we come to Vogt-Koyanagi-Harada syndrome. Diagnosis criteria, no history of penetrating ocular trauma or surgery, because if this is the case, then you'll be thinking about sympathetic ophthalmia as one of your differentials. No evidence of other ocular entities. Bilateral ocular involvement with characteristics early or late manifestations. I'm not going to go into them. They have neurological or auditory findings. They usually have hypercosis, and some of them usually have dizziness, headaches, neck stiffness, all this in part and parcel of the VKH. Integumentary findings are alopecia, poliosis, and vitiligo, so very important to look at these patients. Now, this is how they usually classically present. They usually present with disc edema, and they present with this bullous fluid. You can see it's very classical. There's a fluid pocket here, there's a fluid pocket here, and if you look at this image here, there's a fluid pocket. This is the other patient, you can see. These are pictures which have been taken from a textbook. It's not one of my patients, but you can see here there is a bulle, in which you can actually tell on the fluorescein angiogram with late staining. And this is how they present in the late stage with sunset glow fundus. I have a patient who was referred to me. She's young, she's around 22, 23 years old. One of my colleagues referred her to me in Kenyatta with reduced vision in both her eyes. One eye was counting fingers 1 meter, the other one was counting fingers 2 meters. If you do a fundoscopy, you'll actually see this bulla everywhere, around the macular area, and an exudative retinal detachment in the inferior area. When you take a history, all the investigations were actually negative, So we put on methylprednisolone, pulse, and the treatment of these patients is normally you give a pulse of methylprednisolone for around 3 to 5 days, observe them. If they're not getting better, pulse them again. And the key is give them steroids, at the same time put them on immune modulators. So we started on methylprednisolone and put on azathioprine as my first line of therapy. And we saw her, I think, last month. She's doing very well with 6/6 vision, both eyes. Okay, now, however, she wants to stop the azathioprine because I think she's intending to get pregnant. Now, that's another nightmare for us. So, these are the tests that you can actually do in uveitis. There's quite a lot, but as I mentioned, always look at the patient, see what you think, or what is your presumed diagnosis. Okay? Prof. Kishi also used to tell us when he used to see corneal ulcers in the clinic, don't give machine gun therapy. Think what could be the probable cause and investigate in that line and treat in that line. And one thing I'll tell you about uveitis, don't be ashamed to change your diagnosis as you go along the treatment. You may find that this patient, you thought of this, and along the way you think of something else. Always be very open and very, very broad. It's like polygamy. Have another diagnosis along the way. No, it is a fact. She's not supporting. Now, this is a young patient whom I had seen some time back, around 5 years ago. He's around 30 years old. He came with one eye, left eye reduction in vision. He was sent for TB tests, the whole load of uveitis armamentarium, which is in our pockets, but very deep for the patient's pocket. Any guesses? Was sent for TB tests, by the way, because it looks almost like, sorry?
It's a type of multifocal choroiditis.
Yes. This is what I saw in the patient. By the time he came to me, that's actually an intraocular worm. Just the diffuse unilateral subacute neuroretinitis. And to be very honest, the first time when I looked at the patient, I almost missed it. I thought it's just a subretinal, like a band. Then when I looked again, I saw that thing moving. I was very happy actually, but the patient was not. So you can see, this is where I started doing the laser. The thing moved, came here. I started doing more laser, the thing moved. Finally, I was able to capture it here. And you can see this is the worm which I've lasered. So in conclusion, tailor your investigations, okay? And plan your treatment according to the type of uveitis. And don't be afraid to tell the patient that you cannot identify the cause. Normally, sometimes what I do is if I can't, I usually send to a colleague, take a second opinion. There's no harm in it. And one thing is also, we all think about steroids. I know most of us, when we see a patient with uveitis, we think like, anyways, I'm going to treat this patient with steroids. But that is not the case. You'll be so surprised that most of the times if you can find the underlying cause, you can actually treat the patient and the patient will be happy and save the eyesight. Now, this is in 2012. I don't know, for those who have done uveitis, this is Philip Murray. He's the guy who has written the Oxford textbook of ophthalmology. This is Annabelle Okada from Japan. She's done the most amount of work on Vogt-Carnagi-Harada syndrome in the world. And that's the late Manfred Zuert, the guy who has come up with the guidelines of treating lymphoma in the eye and masquerade syndromes. He's the late, unfortunately, he himself passed away with cancer. So this is in 2012. Thank you very much.
Thank you, Dr. Hatim. Uveitis is such a wide topic that being able to cover it in such a short time is no mean feat, Dr. Hatim. Let's give him a better clap. So we are going to move into the Q&A session because our time is far much spent and we still have a presentation from the sponsors of this symposium. We'll only take 3 questions for Dr. Lily and 3 questions for Dr. Hatim. And then you can have some comments from the experts in these fields. So any questions? You can just raise your hand. You can just tell us your name and where you work and then pose your question.
Hatim Duidar, veterinary surgeon at Aga Khan. My question is to Dr. Hatim. You mentioned in the treatment of uveitis, if the patient visual acuity is not less than 6/12, you don't treat. But this will not go with more inflammations and because usually when we see the inflammation, even if it is just in the anterior segment, we start directly whatever the visual acuity.
Well, this 6/12 is actually a WHO guideline. So if you find a patient who has got 6/12 vision or better and has no other problems like no cystoid macular edema, and preferably they don't have any, like in terms of visual debilitating disease, in terms of they're not complaining of a lot of floaters and all that, I would prefer to observe them. But you keep them under close follow-up. And what I mean by do not treat them means that you have no underlying cause. So if you've not found any underlying pathology which is causing this, then I would rather observe them. But if you find that these patients have maybe, like, supposedly you find them having toxo in the periphery, okay, not involving the macular region, or you find them to be TB positive, then go ahead and treat. But if there is no underlying disease, pathology which we have, basically if we have excluded the treatable causes, then observe them.
Usually we saw some of those patients are the patients with minor trauma to the eye, which comes after many weeks, okay, complaining of that my eye, I got a trauma in my eye, and then I've been treated as an infection or whatever, okay, and then you discover there is a reaction in the anterior chamber. The vision is still good, but the reaction is there. I usually treat, but I need your opinion.
Well, if for anterior segment inflammation, if they do have post-trauma, most of the times is because of the traumatic uveitis. And if they are complaining, then treat them. But sometimes what happens is these patients who have these vitreous floaters, you'll be more than surprised that it's a PVD, which people mistake it for intermediate uveitis. And most of them are actually put on armamentarium of steroids and all that. But if they do have inflammation in the anterior segment, okay, then go ahead and treat. Even I would treat. But if a patient comes with an anterior segment which is quiet, and you see vitreous floaters and cells, then observe them. If you have a vision of 6/12 and better, and there is no infective pathology that you find. Because sometimes these patients actually, okay, it's not very common in our setup, but amyloidosis is a very common problem. I don't know, I've seen so far one case, the one which I've mentioned, but it's something which we need to rule out. And the only way we can do it is to take a vitreous biopsy and send it for Congo stain. That's the only way we can diagnose, and that's in liaison with the rheumatologists. Personally, I don't prefer to do anything invasive. I watch them.
Any other question? Most likely it's yours.
Hi, Tim. Thanks for a very comprehensive talk. I'm just curious. We work together, of course. At what point do you advise, like, to introduce the non-steroidal the immunosuppressants, mycophenolate, methotrexate. How long should the uveitis have been going on? Or what guidelines would you give guys here when to introduce azathioprine and things like that?
The main guideline of starting patients on immune suppressants is basically any patient who cannot take steroids for very long, number one. Supposing the patient is diabetic or has had comorbid conditions in which steroids are contraindicated, you start them on initial pulse of steroids and immediately switch them to immune modulators, number one. And number two, if you feel that this patient is going to have a protracted course of disease, like supposing a patient comes with TB, intermediate TB uveitis, once you treat the TB, the patient will get better. So that one at least. But if you look at autoimmune problems, especially like things like Vogt-Koyanagi-Harada syndrome, things like sympathetic ophthalmia, okay, which are autoimmune mediated, these patients, personally, I prefer to start them earlier on immune suppressants to avoid the debilitation of the steroid. Because you'll find that most of these patients, when they're put on steroids, over a long time, they get secondary diabetes, they get osteoporosis, and the works, the myriad of problems which we find with steroids. And if you look at it in terms of immune modulators, currently, most of the immune modulators given at a moderate dose or at a specified dose, the side effects are very less. And patient comfort is even better. But in patients in whom you think you're going to give steroids for a long period of time, try and switch them to immune modulators. And the good thing is, you see, with patients is once you sensitize them early, that look, this is what we're expecting. And usually I tell my uveitis patients it's a very bad marriage between you and me. You can't divorce me, but we are in a marriage. So it's a long-term relationship we have. Till death do us apart in some of them. So be prepared for a turmoil, up and down, but I normally sensitize them that this is, look, and you see, at the moment, most of our patients are very well educated. You give them, and I know there's something we call Dr. Google. I know my wife, when she gets a headache, the first thing she does is she Googles and tells her there's cancer in the brain. And lo and behold, things start from there. I'm sure most of you have had those problems. The patient comes and the first thing you tell them something, they open their phone, they Google. So the best thing is let them Google themselves. So I usually write for them that this is the immune suppressants I want to give you, this is your diagnosis, and this is your progression of the disease, and this is how it's going to be with me. And most of the times the patients will make an informed decision. I hope I've answered.
Good evening.
There are no questions for Lily?
No. Okay, my name is Dr. Munira. I work for the Ministry of Health, currently ish in Kiambu. So this is for Dr. Hatim. I wanted to know, is there a role for non-steroidal anti-inflammatories, especially in patients whom we have been managing long-term for uveitis and trying to wean them off the steroids without getting the immune modulators on board? Thank you.
If a patient comes to you with acute anterior uveitis, initially treat them with steroids over a protracted course of 4 to 6 weeks, and then observe them. Non-steroidal anti-inflammatories, normally I would say it's mainly for you sleep well. You feel like you've given the patient some dawa to go use at home, so they even sleep better and you sleep better. But ideally, if you look at it, non-steroidal anti-inflammatories per se don't have a role in uveitis over a protracted period of time. The only time you would think of giving them non-steroidal anti-inflammatory medication is orally, especially patients who have scleritis. And even that if it is non-necrotizing. If it's necrotizing, shoot them with steroids with all your might, because otherwise the sclera is going to melt. But if your patient comes to you with scleritis, episcleritis, yes, I would agree, because it's basically an inflammation on the surface, you can treat. But other than that, you're just treating yourself. I do it myself as well. I will not deny that. It makes you feel better and sleep better. But other than that, it has no role.
If I can comment, I'm Oscar Onyango. I'm definitely KNH, not approximately KNH. Maybe approximately Nairobi Hospital. But anyway, just to comment on Munira's question, NSAIDs used in cyst and macular edema, you know, before the era of steroids and anti-VEGFs and things, you could give Indocid, high dose, steroid high dose, and you see how that goes. I've had a few patients who've responded to that. Of course, the systemic side effect is there, gastric ulcers and all. My question to Lily, two things. When we're in training, we used to talk about lamina cribrosa exposed and I don't know what, those things in glaucoma and things. What happened to that? You don't talk about that anymore. That is one. Two, you have this patient with, we talked of raised eye pressures up to, well, normal pressures up to 21. Okay. They have patients who have borderline pressures from 22 to 30. Normal optic discs. The guys are Googling, as Hatim was talking about. Do you put these guys on treatment? Is it ocular hypertension? Pachymetry is normal. The cornea is not thick. We used to talk about a standard thickness of 515, I think, was it nanometers or something? For the corneal thickness, that was what the Goldman's tonometer was based on. Are we still basing it on that? So what do you do? What's the standard corneal thickness in terms of pachymetry? What is seen as high, as thick? What is seen as thin? Yeah.
So thank you for that question. At least I got a question. So for the disc morphology, I didn't cover, yes, you can look at lamina cribrosa and all that. But what I was trying to do was to narrow down to what you must get at least. And that's why I said the cup disc ratio, and it's true, you can see the lamina cribrosa is exposed because that is actually where the nerve fibers pass through. So I think in a clinical setup, first find if the patient is suspicious of glaucoma or no glaucoma. So once you're able to see whether the disc, and that's why you have your cutoff of 0.6, the disc asymmetry, the disc size, etc. The next question you had was for ocular hypertensive patients. You have a patient, normal corneal thickness around 554 microns. Normal corneal thickness has very high pressures, 30, right? Normal disc morphology, everything else is normal, right? For me, at least in my training, and remember I told you the risk of glaucoma goes up. By the time you're clocking 30, you're at two times more likely than the general population to get glaucoma. When I was training, for us, the cutoff was 25. Okay, by the time a patient is passing 25 millimeters of mercury, because you also don't want to have retinal vein occlusions and those retina issues, then at least, and it's not an artificially thick or thin, artificially thick cornea, I would recommend have a cutoff of 25. You can put on one drop, 25, by 30, one drop, the patient should drop down to less than 25 so that you can avoid those complications, which we do want to send patients to you for. Okay? Did you have another question? Yeah. 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 Mm.
We see those regularly, and most of them tend to be learned people, quite, professionals, doctors, lawyers, and things. And they have read about glaucoma and they're worried.
Yeah.
And so how often do you repeat a visual field? You know, how often do you do the OCTs? How, this kind of patient, yeah.
So it's good you asked about the ocular hypertensive patient, because those ones can be tricky. So remember, 25. For visual fields, OCT, etc., if I am able to, it depends. And I remember I told you the guidelines are there. We have them, but also rely on your clinical acumen. If I'm able to get a patient who's able to come for my follow-up visits, is able to afford the tests, what I was trained and when I was being trained, and I see why, because that's when you're able to detect any progression is 6 months. 6 months is objective enough. You can send the patient back, you can test the optic nerve. If there's a difference, you'll see it in 6 months. In 6 months, you can be able to see if there's an RNFL defect on your OCT, if it has increased by 4 microns or not. In 6 months, you're able to see a visual field. So that's the 6 months is based on ample time that gives you time to be able to make a decision. Is this patient, like what we do on your, once you've stabilized, you've diagnosed your patient has glaucoma, you've been able to stage your glaucoma, you've been able to get your target. Because the first time, usually you're telling patients, start these drops, come back after this number of weeks, start these ones, add more, until you get to your target. So once you get to your target, then now you want to give your patient a span of 6 months so that you're able to make a conclusion. Is my patient stable or progressing? In glaucoma, your optic nerve will not get better, okay? It just remain, you hope at least it stays stable. So that 6 month mark. The thing is that as much as we write these guidelines and say 6 months you need to do tests, we all know that we're in a country where things can be hard. I mean, it's expensive doing these tests. Okay, so now I've become less stringent. At least I beg you, please do it in a year. Yeah? I'll still check you in 6 months. I'll do my optic nerve assessment. I'll do the IOP. I'll make sure on target. But at least, if maximum, don't go beyond a year. But sometimes you still get patients going beyond a year. So I think I would straddle that around 6 months. That's enough time to give you time to see if your patient is stable or not stable. And in 6 months, you can be able to reset a target, okay? Based on the next grade that you'll give them. Remember, this grade and target keeps, I mean, this time it could be mild, and then you skip over to moderate glaucoma. So the target also changes during your follow-up visit. So always remember that. You have different targets for different stages of glaucoma.
Okay, I have one question for Dr. Lily and one for Dr. Hatim, and then we'll move to the next session. We're still going to have dinner, so you have enough time to still ask them one-on-one for if you have any more questions. So maybe Dr. Lily, because you have the mic, what is your expert opinion on phasing in management of glaucoma? I know those of us who've gone through your N in first year would be kept there the whole day, taking IOPs morning to evening. So what is your opinion about that and its role in management of glaucoma? And then I'll also just ask my question to Dr. Hatim. What is your opinion, or do you practice periocular steroid injections in managing uveitis? I've seen this practice elsewhere. I don't see a lot of it here, but maybe you can just tell us what is its role, do you have experience with that, and would you really recommend it?
So it's good you brought about phasing, and you realize the history and examination in glaucoma, all these things you're trying to get risk factors. Many of them you can't modify, but it also, the importance of the risk factors is to help you sometimes even decide, like for the ocular hypertensives, whether you're starting treatment or not, okay? Now, phasing gives you that diurnal range, which is a risk factor for glaucoma, yeah? Most of them have about 6, some of them have about 6, yeah? The thing is that, as I told you, you have to have a clinical acumen. If you're having queues of 30, 40 patients, then it may not be the most practical thing. If you're able to do it, depending on your practice, and add an extra risk factor, then you can do it. But if you look, I think when you're making decisions like phasing and things like that, first look at your circumstance, if you're able to do it or not, then look at the evidence. If you go to PubMed, look at the published studies, does it add that much value? Maybe for the other glaucoma people in the room, does it add enough value for you to keep probably patients 24 hours facing? But I'm not discrediting it. It's important to at least add on to your decision making. But sometimes you also have to see, if it's practical. That, I think, is an opinion. It's not been randomized in any clinical trial, so I think that remains your judgment as an expert. Anyone else with an opinion on phasing? Yeah.
It's a good idea to do phasing because it will give you a more objective measurement of the IOP. And remember, there are those whose IOP changes even at night. Yeah, so at least for normotensive glaucomas, you'll be able to pick them up, and that will be of, benefit to your practice.
So you can see different trainings, different opinions. So, and you, what do you think?
Okay, I think it's important, but it can be a bit not practical depending on the setup where you work, so I agree with you. Okay.
I'm not kicking it out completely. Another thing, maybe that can be important with phasing, as much as maybe some of us may not practice it more, is getting the Tmax, the highest IOP, at least having a high IOP where we are starting from. But anyway, still in the end, your patients will not be, even when they come back for follow-up, yes, you get this range, then they come back for follow-up, you still have your target, but she's right, for the normal pressure, maybe if you get the Tmax, you'll still have to do, it's so controversial. I think you'll need that's why I said, one thing I learned when I was doing my research fellowship, which helps me even in my clinical work, is that sometimes you have certain things and you have to now make a call whether it's adding value to your practice or not. For me, I think many times is if I'm in a gray area and I'm not sure what to do, maybe look at the trials, the randomized trials. That helps you. There are not so many in the eye, so if you really want to hone down your treatment and your management, probably stick to the randomized trials for guidance. Or what you prefer, if you feel comfortable that this I have to do, then probably stick to that, okay?
Thank you so much, Dr. Lily. Yeah.
Brenda has asked a very important question regarding subtenon triamcinolone, or steroids, basically. Well, anterior uveitis, I wouldn't give subtenon steroids, but patients who have intermediate uveitis and posterior uveitis, it does have a role. And I normally give, okay, I might be biased, but patients who have severe uveitis, they get most of the time cyclitic membranes, ciliary body detachments, and they usually come with persistent hypotony. These are patients in whom I usually prefer to give subtenon triamcinolone, and patients with intermediate uveitis who have been taking steroids for long, you find that when they take steroids, they get better, and they're not willing to take immune modulators. And whenever you stop the steroids, after maybe like a month or so, they come back with recurrent inflammation. Sometimes I do prefer to give, but I always tell the patient that these are the risks that are involved. That number one, there's a risk of IOP elevation, there's a risk of cataract formation, especially in young patients. Though it's not only because of the steroids, the uveitis per se will also give you a cataract. But these are always discussed with the patient, and if they're in agreement, I do tend to give subtenon triamcinolone steroids. Now, something of a controversy, I know people in the bulb right now are also giving retrobulbar steroids for patients who present with recurrent orbital inflammatory diseases. They usually give triamcinolone the same way we give retrobulbar injections. I have never tried it. I don't know if any one of the people in the crowd who have given it a try. Personally, I'm not very comfortable, so I don't do it. But subtenon triamcinolone and steroids, yes. And one thing to just send a message home, patients who have uveitis, please try and avoid giving them triamcinolone intravitreal. because you will not know whether it's your uveitis which is getting worse or is it the triamcinolone which is making it worse. So preferably, if you want to give an intravitreal injection in patients who have uveitis, preferably give dexamethasone, or the better choice of option is Ozurdex and other steroid-based which are not available in our setup right now, okay? But they're very expensive. So that's the option you can give, but try and avoid giving intravitreal triamcinolone because it will be a mess for you. You will not know whether your uveitis is getting better or is it the triamcinolone you're seeing in the eye.
Thank you so much, Dr. Hatim and Dr. Lily. Allow us to stop the Q&A session there because I know glaucoma and then uveitis are very wide topics. It's really hard to exhaust in a very short time. Feel free to ask them when you are having dinner. So we still have another presentation from Bliss GVS, who are our hosts and the organizers of this symposium. So at this juncture, allow me to call upon the GVS team to take us through the next sessions. Thank you.
Thank you all of you. Thank you, Dr. Brenda. Thank you, Dr. Lily, Dr. Hatim. Now I would like to take through our products of Bliss GVS Pharma. And I would like to tell you that Bliss GVS Pharma products which are manufactured in all US FDA approved plant in India. So I will take through our products. We have in glaucoma products, we have the wonderful, that is a timolol malate. The brand name is Olotame, which is available in 5 ml pack. And we have also Bromolon, that is a brimonidine tartarate 0.2% is available. The brand name is Bromolon, 5 ml vial pack size. And the another is Ocularide, which is a dorzolamide 2% eye drop, which is also available in 5 ml vial pack. And we have with the timolol combination also, that is dorzolamide 2% plus timolol 0.5% eye drop, which is available in 5 ml pack. And comes to the latanoprost 0.05%, which is also available in 2.5 ml vial pack. This is Oloprost is a brand name. And we have a combination also, that is latanoprost plus timolol combination with 0.05% plus timolol 0.5% in 2.5 ml pack. And we are also coming with a bimatoprost as well as travoprost in the coming phase. Now we have the anti-infectives and anti-infectives plus steroidal combination. The first brand is available, that is ciprofloxacin 0.3%. The brand name is Zipro, which is available in 5 ml pack. And we have a combination also with dexamethasone 0.1%. The brand name is Zipro DX, which is also available in 5 ml pack. And coming to next, we have a Floximax, that is a moxifloxacin 0.5% eye drop, which is available in 5 ml pack. The brand name is Floximax. We have the combination also with the dexamethasone 0.1%, that is a Floximax DX, 10 ml vial, that is 10 ml pack is available, Floximax DX. And another is, we have the gentamicin, we are launching in a phase wise. The brand name is Yotam. Its composition is gentamicin 0.3%, 5 ml vial pack. Plus we have the combination also with dexamethasone 0.1%, that is gentamicin 0.3% plus 0.1% dexa, that is Yotam DX. And we have Yonem BT, the brand name is, which is combination of neomycin plus betamethasone combination of 0.01%, available in 10 ml pack. That is the brand name is Yonem BT. And the next one is Yonem DX, that is neo plus dexa combination, which is available in 10 ml pack, Yonem DX. And we are also launching fluconazole 0.3% eye drop and chloramphenicol 0.5% eye drop. Then in tobramycin 0.3%, which is a brand name is Tolo, which is available in 5 ml pack. Plus the combination is also available, that is tobramycin DX, that is 0.1% dexamethasone combination plus tobramycin 0.3% is available in 10 ml pack. The brand name is Tolo DX. And In anti-allergic segment, we have the brand called as Amoglad, which is sodium chromoglycate 2% eye drop, available in 10 ml pack, sodium chromoglycate 2%. And we are also have the olopatadine 0.1%, that is the brand name is Olota, available in 5 ml pack. And we have the eye lubricant, the brand name is Izuvi, which is combination of sodium CMC 0.5% plus sodium perborate 0.05%. The brand name is Izuvi. And we are launching the dexamethasone 0.05%. Optadone is a brand name, available in 5 ml packs. And another is a prednisolone eye drop, which is available in 5 ml pack. And in future, we are also launching flubiprofen 0.03% NSID. And this is our entire brands. So we are launching now the brand name which is available today, that is Olotim, Timolol, Maleate, and Amoglad, that is sodium chromoglycate, Olota, Zipro, Zipro DX, and here the Olopros, Latinopros 0.05% is available, plus combination also Olopros T, and we have Ocularide available, Dorzolamide eye drop 2% plus combination of Timolol. So I would like to request all the respected doctors, please bless with your support in terms of prescriptions, in terms of your support. And I request all of the doctors, thanks for your patience for attending the symposium in behalf of Bliss GVS Pharma. Now we call for the enjoy for the lunch, dinner. The dinner is available outside this hall. So I would like to request all of you to please enjoy your dinner. Thank you so much for your wonderful. Thank you. Thank you. So I request all doctors, please enjoy your dinner. Thank you.
Good evening. Once again, I'd like to thank you, all of you, for coming here, coming out of your busy schedule and coming here. As a Bliss GVS, this is the first launch in the ophthalmic division, and we request for your support for our products. So initially, we, as my colleague Mr. Nalil has told, that we are going to launch like 25 products, but the basket is going to increase in a phase-wise, and we seek for your support. Thank you so much.
That marks the end of our very enlightening symposium and discussion. So, okay. So we are now ready to have dinner. Feel free to queue outside for dinner. There'll be some few photos which will be taken as we eat and, organize photos. But for now, everyone is allowed to just queue outside, have dinner. If you still have any questions, any doubts, Dr. Lili is still here, Dr. Hatim is here. You can ask as we have our dinner. Oscar is also here. I saw Dr. Nyamori somewhere. So feel free to ask any doubts that we have in these topics. Thank you so much. Thank you for creating time to join us for this symposium. Enjoy your dinner and have a good night after that. Yeah.
Thank you. Just 5 minutes, I'm playing our corporate video. Excuse me.